Thank you very much. Thank you for that introduction. I am very delighted to have this invitation. I would have loved to have the opportunity to be in Turkey in person, but unfortunately, COVID made my plans change. So I had to do this through a live feed. But I'm looking forward to your questions, and I hope we can make this as interactive as possible. What I'm going to talk about this morning is sleep and ADHD, something that I have been studying over the decades with the idea that there is such a close relationship that we should be considering this a 24-hour disorder. ADHD by day, sleep problems by night. These are my disclosures. I have consulted to pharma. I have book royalties. I anticipate to have royalties from a measure I created to look at functional impairment, which is translated into Turkey. And I also have worked to create digital apps for ADHD, which is something that I think has a promising future. The learning objectives of what I'm going to be talking about today. First, to describe the close association between sleep problems and ADHD problems cross-sectionally at each stage of the life cycle. Then, to move from that association to something much more challenging, which is to show whether ADHD at one stage of life predicts sleep at a later stage of life and vice versa. Then finally, I want to look at what this means for us as clinicians, because I think it has very significant clinical meaning. It is possible to show that when we treat the sleep, the ADHD gets better. And when we treat the ADHD, the sleep gets better. So I'm going to talk about what we need to be doing differently in our clinical practice to take advantage of this understanding of sleep and ADHD as a 24-hour disorder. I just wanted to highlight this book because it was a labor of love by all the experts in sleep and ADHD worldwide. It's short and it's very easy to read, and a lot of the information that I'm describing is included in this book. You can see here that although I said I have been studying this certainly for the last 30 years, this is an area that has grown exponentially, and you can see that reflected in the number of publications. So we are nearing 1,000 publications specifically reporting research on this association. The idea that I expressed that ADHD and sleep are a 24-hour disorder was first described by Mark Stein and myself in a paper in 2012, then again in 2015, and I think it has now become part of our language because in a major review by an expert from Cincinnati, United States, Stephen Becker, he again talked about ADHD and sleep as a 24-hour disorder. He asked the questions, which are of such clinical and research interest. Why? How do sleep problems emerge in ADHD patients? Who is at most risk for sleep problems? Which functional outcomes are most impacted when the child can't sleep or has ADHD? And these are some of the questions we're getting closer to answering and that I'm going to be talking about today. So let's first look at the cross-sectional studies showing the association at each stage of the life cycle. This is really quite remarkable because this research now is consolidated. Not only are there many studies, there are excellent, large meta-analyses of these studies. So, for example, Cortez in 2009, really the pioneer of meta-analysis, showed that children with ADHD have greater sleep disturbances, not just subjectively by parent report, but also objectively on things like actigraph and polysomnogram. In adolescence, the connection between ADHD and sleep problems gets even worse. That's partly because adolescents are prone to having difficulty falling asleep early and tend naturally, even when they don't have ADHD, to have a delayed circadian rhythm where they don't get sleepy until very late. So adolescents with ADHD have more than 6 times greater parent-reported problems with sleep, and not only subjective reports, but abnormal actigraphy. The same is true, what's true in childhood and true in adolescence is also well demonstrated in adulthood. And there is, again, excellent reviews that summarize all of those literature. I would recommend the review by Diaz-Roman in 2018. So what are we talking about? We can say this is a close association. We are talking about a majority of patients with ADHD. So when a child walks into your office with ADHD, there's a 70% chance that he has one or another sleep problem. With an adult, that's even greater, more than 80%. Now, that depends a little bit on how you measure the sleep difficulty, but take it for granted that there will be sleep problems in your patients. The ADHD patient who is sleeping really well is the exception, not the rule. So what are the sleep disorders that are common in ADHD? The first is what we call intra-individual variability. What that means is for that given person, their sleep schedule is very irregular. Typical is an adolescent who stays up till 2 in the morning and then has to get up for school at 8 o'clock, but makes up the difference by sleeping in till 2 in the afternoon on the weekend. The other major difficulty associated with ADHD is what we call circadian rhythm alterations. Individuals with ADHD are much more likely to fall asleep late and wake up late. Instead of getting tired at night, that's when they wake up. That's when they feel they can focus. And so that's when they often get their work done. And Roy Gruber, a sleep expert in Montreal, has coined the phrase eveningness to describe this phenomena. ADHD is also associated with behavioral insomnia. ADHD individuals are dysregulated, and many of them are oppositional. I won't go to bed. That's true for children. It's also true for adults. Ironically, and this is partly the remarkable work of Michel Lefondreux in France, although individuals with ADHD look hyperactive and very busy, in fact, they can have borderline narcolepsy on a mean sleep latency test. They're actually tired, almost like an overtired child. And so given the opportunity, they will fall asleep almost instantly. In a meta-analysis of sleep and ADHD, Ferron made the very important point that we often assume the problem is going to be falling asleep. But the problem is just as likely to be waking up in the middle of the night or waking up early in the morning. ADHD is also associated with classic sleep disorders like sleep apnea, restless leg syndrome, periodic limb movement disorder. And actually, when I say ADHD and sleep represents one consistent disorder, you can see this or interpret it to some extent as hyperactive movement by day and increased movement by night as well. So what we are seeing here is social jet lag, the misalignment between when someone with ADHD goes to sleep and wakes up, and the requirements for appropriate timing of sleep for school and work causes a lot of problems. We do believe that this may be related biologically to a 2-hour delay in the onset of dim light melatonin. And this difficulty with sleep causes a lot of problems. If your child never sleeps, you are an exhausted parent. Taking care of an ADHD child is exhausting to start with. Without sleep, that is even more difficult. If you do sleep, it is as likely as not that your ADHD child will be up, running around the house, and lacking supervision, which can be a significant difficulty. Believe it or not, this is such a big issue that sometimes children with unentrained circadian rhythms, meaning they're sleeping randomly during the day or sometimes late at night, sometimes early, causes so much problems for parents that it has led to a foster placement. So as I mentioned, looking at the biology, we know that dopamine and melatonin are on the same pathway. And in fact, the iron and zinc deficiencies, which are common in ADHD, represent cofactors for those pathways, which may go some way to start to explain this close and tight connection. We also know that the use of melatonin can correct some of these problems, and this has been a major development. Melatonin, the way it's commonly used, is a way of helping a child fall asleep. But as I mentioned, these people also have middle of the night waking, and melatonin used differently can help with that as well. Excuse me. Sorry. So now that we know that there is a close association between ADHD and sleep, let's look at the ultimate test, whether one can predict the other. Here we see a huge twin study done by Gregory. He looked at over 2,000 twin children and found those with ADHD. His criteria for diagnosis of ADHD was remarkably rigorous. He did structured interviews at ages 5, 7, 10, and 12, and 18, and got parent and teacher reports, and only made the diagnosis if they were positive at least 2 points in time. So we are very confident that he found an ADHD sample within a large population. He took this population and then he measured sleep with a measure called the Pittsburgh Sleep Questionnaire. So I'm going to call it the PSQ in early adulthood at 18. And what he found is the children who had ADHD had more problems with sleep when they were adults, but only if they were still ADHD. If the ADHD was gone, the sleep problem was gone as well, from which he concluded the association is an association of state, not trait. This is an article that is currently in press, and Mark Stein and I also wrote an editorial. It is coming out in the next issue of the Journal of the American Academy of Child and Adolescent Psychiatry from the United States. This was a population study of more than 1,000 French parents. And one of the advantages of doing this study in France is the less than 2% of patients in France receive stimulant medication. So stimulants were not a complication. They looked at, in each of these three waves, latency, early adolescence, early adulthood. Did the sleep in one predict the ADHD in the other? Did the ADHD in one predict the sleep in the other? They found, as with all the other studies, that people who had problems with sleep, it tended to be through the life cycle. People who had problems with ADHD, also consistent across time. What they found is ADHD symptoms at 13 predicted sleep problems at adolescence. So there is an association at each phase, but there's also a predictive longitudinal relationship. ADHD and sleep were always connected, and also there was predictive. So the conclusion of the study is that there was evidence of a directional longitudinal association between parent-reported sleep disturbance and ADHD symptoms from childhood to early adulthood. I want to emphasize there are very few studies in the history of psychiatry that say something found in childhood predicts something in adulthood. The most famous example are the studies of adverse childhood events, where we showed that problems with trauma have a whole range of negative physical and emotional outcomes that are clearly associated in adulthood. But apart from that, longitudinal associations only are found when there is a very robust connection. There are also studies, there's a study from Brazil, the Pelotas birth cohort, that showed that sleep problems in infancy predicted ADHD in latency. And longitudinal studies that show when the symptoms improve, so does the sleep. The hypothesis then is the reason this is a 24-hour disorder is because both disorders represent dysfunction in arousal. So in conclusion, we have seen two different studies, different methodologies. A twin study showing that sleep problems in childhood was associated with ADHD in adulthood when it persisted, and another large population study that showed ADHD in childhood predicts sleep problems in adolescence and vice versa. Totally different methodologies, same conclusion, heavily weighting our understanding of the depth of the connection between ADHD and sleep. Note, however, that in adulthood, ADHD changes from being a disorder of hyperactivity, the way it presents in toddlers, to a disorder of attention. So that connection is a connection with attention problems. Does this matter? The answer is it matters a great deal. When we do sleep restriction studies where we empirically prevent people from sleeping, whether they have ADHD or not, we find that this causes ADHD symptoms. I did a study, I'm going to tell you more about it, in which we looked at the functional impact of the sleep and the ADHD. Another study showed that sleep as measured by the Child Sleep Hygiene Questionnaire had a moderate correlation with functional outcome. So sleep predicts functional outcome. In addition, sleep problems predict other things, like problems with depression, problems with being oppositional 1 year later. So this is the study that I am describing, where we looked at how much does this matter. We had 192 children with a mean age of 10, and we looked at ADHD, quality of life, mental impairment. As said, we found the most common sleep problems were actually excessive daytime sleepiness, sleep disordered breathing, movement, and sleep variability. All of these things were connected with parent and teacher report of ADHD symptoms. And remember, teachers don't know how the child is sleeping. The most important finding of the study was that the sleep and the ADHD independently predicted both quality of life and functional outcome. So sleep causes trouble. ADHD causes trouble. Sleep and ADHD, the most common presentation, causes the most trouble. So if this is a 24-hour disorder, how does this affect treatment? Why does it matter? The first thing I would emphasize in terms of changes to clinical practice is if you do not measure sleep when you do your ADHD assessment, you will not know about this. Probably just saying, how are you sleeping, will give you something. But if you use a measure, clinically, you could use the BEARS. The BEARS is an acronym for saying, do you have trouble at bedtime? What's your routine? Are you tired during the day? Are you waking up at night? Is your sleep schedule regular? Are you having any problems with breathing? Sometimes I even show what I mean to the parent. I will show sleep apnea, because otherwise a parent may not know to look for it or may not recognize it as sleep disordered breathing. Other self-report measures are really quick and easy to use. They take 5 minutes and they give you a wealth of information. The importance of this problem has been recognized by the American Psychiatric Association, who in their parent-reported outcome measures, this is a battery of measures newly created that are using artificial intelligence to select questions. They have developed very nice 8-item scales for each stage of the life cycle and for measurement of impairment. All of these things are free and available online. My favorite measure is to give this to a parent, because a picture is worth 1,000 words. When you give this, you ask the parent to put an arrow when the child goes to bed, to color in the boxes when the child is sleeping, to put an arrow when the child is woken up, and to then look at, with just looking at this, I can see that this child is being put to bed at very different times every night, that there is over 2 hours of time between when they fall asleep, when they go to bed and when they fall asleep, and that they have no entrained circadian rhythm. I show this to the parent. The very act of measuring it improves the parent's vested interest in improving this. And when they come back after treatment and all the lines are lined up, the bedtime is regular, the sleep onset latency, the time to fall asleep is now no more than 30 minutes, and there is consistency, and the colored boxes are showing no awakenings at night. This is a major achievement which will reflect improved outcome and can endure. So what is very interesting is for the first time now, we have clinical trials by Hiscock and Sybaris, the people who wrote that book that I just told you about, demonstrating that it only takes 2 sessions of training a parent on how to put their child to sleep for sleep to go from being very dysregulated to being normal. So improving sleep will improve the ADHD. 50% of the change in the ADHD came from just improving the sleep. Multiple studies have demonstrated that opposite is also true, and I'm going to discuss this in some detail. When you treat the ADHD, and this will come as a surprise to you, I'm sure, when you treat the ADHD, even with stimulants, for the majority of patients, sleep will improve. Some patients will have sleep as an adverse event early in treatment, but if you look at all patients over time, more people will go from being bad sleepers to good sleepers than the other way around. So the moral there is when the ADHD gets better with stimulant, this does not occur at the expense of sleep. Clinically, it's very helpful to correct a lot of the myths that are associated with ADHD and sleep. Many parents, I would say most of my parents, tend to think their children are not getting enough sleep, and so they try and deal with that by putting them to bed earlier. That's actually the worst thing you can do. There's another reason they do that. They're tired. They need the parent needs their child to be in bed at 7 for them to finish their work and clean the house and have a little bit of time for themselves. The average parent needs 8 hours sleep. The average child with ADHD is getting 6.5. What happens then when you put a child to bed too early is not only do they not fall asleep, they don't even fall asleep then when they otherwise would have become tired. Children need, according to parents, 12 hours sleep. Actually, they need about 9.5. This means when sleep experts do their work, often the first thing they do is sleep restriction. No 12 hours sleep, 9.5, sleep less and sleep better. The other thing that happens in clinical practice, we know that ADHD in children is associated with ADHD in parents. We know that sleep in children is associated with sleep disorders in parents, and we know the two go together. That means that it is very common in clinical practice that you're dealing with a chaotic household in which no one is sleeping. Parents who don't know how to sleep cannot teach their children how to sleep. And sleep is a developmental skill. So this dysregulated schedule, problems with regulation in other areas such as exercise, means that the problems with sleep and ADHD dysregulation infect many other areas of functioning. Your patients will tell you sleep is boring. When you say to your patient, go to sleep, they don't want to. And what they say, it's so common to hear this. I cannot turn my thoughts off. So without the melatonin and with eveningness, they don't experience what a normal child experiences in terms of getting tired and sleepy. So this requires quite a lot of work at multiple levels, treating the ADHD, treating the sleep disorder, treating the parent, setting up the sleep schedule. You have to do wraparound care with improvement in all these areas to get improvement in the outcome. This is a study I did a long time ago in 2006. It's my favorite study. And it's a little strange to me that it's never been replicated. So what I showed in this study is shown on the graph on the right side. About 28% of patients with sleep problems improved with just sleep hygiene. And their sleep difficulty went from what we know it is, 90-minute delay, to a little over an hour. We then added a placebo to test placebo effects. Very little difference. Maybe 10 minutes difference between sleep hygiene alone and adding placebo. So the melatonin effect is not a placebo effect. When you add melatonin to sleep hygiene, there is further improvement. You've now cut this in half from an hour and a half to 45 minutes. Once you are using melatonin and a regular sleep schedule, sleep hygiene, intensive personalized sleep hygiene, not a handout, over time, sleep normalizes completely to a sleep onset latency of 30 minutes, which is normal. So there are many studies now. This is one of the first studies of melatonin. There are now many studies of melatonin in many different things, including neurodevelopmental studies. And there are even meta-analysis of melatonin in neurodevelopmental studies. And yet this remains the only study that shows that melatonin works better if it is combined with a regular sleep schedule. I had, for example, last Friday, a 17-year-old who was staying up watching YouTube videos, which is a lot of blue light and arousal, until 2 in the morning, getting up at 7, 5-hour sleep to get to school on time, not paying attention, and his mother's request was that I treat his attention deficit with stimulants. But what I explained is with 5 hours sleep, the likelihood of his having a good response was small, maybe worth a try. But in fact, I realized I had to change his sleep schedule. And by sticking to my guns, believe it or not, I empowered his mother, who was not home because she was working, to set him up that she took the phone away so he couldn't watch YouTube. And that's when things changed. So let's go back and look some more at melatonin. Again, 9 positive studies. This decreases the dim light melatonin onset from 90 to 20 minutes. It's an amazing drug because it's one of the only drugs I've ever worked with, and I do see it as a drug, even if it's marketed here as a food, in which there's no tolerance. And in our study, it's the only study I've ever done in which there were more side effects in the placebo group than in the melatonin group. 50% of the people we worked with stayed on the melatonin for years. People who discover that this works voluntarily want to continue taking it because they feel better. That's the ultimate test of a drug effectiveness. We now know that about 1% of the population is using melatonin, and melatonin in neurodevelopmental disorders in North America has become very, very common. Let's go back to the clinical trials that I talked to you about, in which behavioral intervention, just 2 consults and a phone call, the number needed to treat was 7 patients. The parent training behavioral program was better than 1 session on sleep hygiene. So there is now evidence that what the people in my clinic do, the trainees, here, this is sleep hygiene, follow these rules, does not work. You actually have to do what I said. You have to measure sleep. You have to look at the routine. You have to see what the routine is. The problems with sleep in any individual can be quite different. And the work of fixing it, the work of getting regulation of anything in ADHD families has to be personalized. Sometimes it's easy and it's 2 or 3 sessions. Sometimes it takes much longer. Judy Owens has done remarkable work showing state-to-state differences. She advocated for a later start to the school day in high school, knowing that many of these adolescents need to sleep later, and showed remarkably good outcomes when school started at 9 o'clock rather than at 7 o'clock. These sleep training programs are deeply necessary, but the number of people who are willing to do this or know how to do this remains quite limited. So in Canada, Penny Corkum is developing a manualized program with telephone support in which a lot of the information can be developed online. So online training alone doesn't work, but online training to deliver the information with a telephone call, something that's quite common in Canada as a methodology for dealing with having to manage patients in outlying regions, has a robust effect, is cost effective. In the studies, large studies, the randomized controlled trials, over 300 children who have ADHD and sleep problems, managed either by treatment as usual, the way we do business as usual, or the intervention with 2 consultations from somebody about sleep, showed enduring improvement over 3 and 6 months. And interestingly, it was more effective if the ADHD was also being treated with stimulant. We are currently, for the most part, not doing this. Almost everywhere, the way physicians are managing sleep in children is with medication. And that includes diphenhydramine, clonidine, trazodone, mirtazapine. I don't know the names of these medications in Turkish, but I'm sure the practice there is no different to anywhere else. That means that if there was better understanding and training of what I just described, we might be lowering the use of these medications, all of which are effective at putting the child to sleep, but also interfere with sleep architecture and sometimes have residual effects in the morning. So let's look at what I talked about before in terms of insomnia as an adverse event. No question about it. All of you who use stimulants know that in reality, about a quarter of your patients in the first week as you come back are going to say, my child isn't sleeping, doctor. And this has been well studied. This is a study by Mark Stein. And what he found was that insomnia was present in 5% in the placebo group, 11% in a medium dose, and interestingly, slightly lower at a high dose. And he interpreted that as a reflection of taking longer time to get to the higher dose so that the sleep problems which tend to occur early might abate. Another possibility, however, is that when you use a higher dose, it lasts longer. And what I'm going to show you now is very ironic and will come as a surprise, which is that children fall asleep easier on stimulant than when they are in rebound off stimulant. So patients with baseline sleep difficulties are going to be more vulnerable to sleep problems with treatment. What that means is the child who comes in to see you with ADHD, and he's one of those rare children that the mother says he sleeps perfectly, goes right to bed, falls asleep instantly, sleeps through the night, and sleep is not a problem. There are children like that. That child is less vulnerable to having sleep problems with stimulant than the children that I described who had sleep problems to start with. It's always the things that are a problem before treatment that are going to be an even bigger problem after treatment. We know that sleep difficulty onset with stimulants in all the clinical trials. I took an average of all the children, adolescents, and adult labels and put together a single figure. In all the clinical trials, short term, about a quarter of the patients are describing insomnia. That may be an underestimate since it's based on spontaneous report. Sleep adverse events associated with stimulants include not just difficulty falling asleep. So when we ask about sleep and we don't use a measure, we tend to say, is your child having trouble falling asleep? And I would suggest that is not the right question, because in fact, we know that the insomnia is not just a question of falling asleep. These children are also waking up. Contrary to what is commonly understood, the ratio of sleep difficulties with methylphenidate and amphetamine is about the same. And that's actually been shown by Mark Stein in 2011, shown again since then. So let's look at meta-analysis that was done by Steve Ferrone on sleep adverse events with methylphenidate. He looked at, these are great studies that we have now, these meta-analysis, 35 studies, 3,000 kids on stimulant, 2,000 kids on placebo, and he looked at every possible confounder, whether it was dose optimized, forced dose, whether insomnia was measured as a change over baseline, whether there was a placebo control group. I would especially emphasize the importance of looking at sleep as a change of our baseline. If you do not have a baseline measure of sleep before you start the stimulant, and then after you start the stimulant, you say to the patient, are you having trouble sleeping? And they say yes, the chances were they had that problem with sleep before you did the intervention and you failed to find out about it. This is, again, a big meta-analysis of 9 studies of sleep as an outcome and an adverse event in clinical trials of methylphenidate, lisdexamfetamine, Adderall, and dexmethylphenidate in adults. And it showed, and I'm going to show you lots of data on this, that is against what you would normally understand when you look at group data. So not the 25% of people that have problems with sleep as a side effect, but the whole group and sleep over time. What you see is people on stimulants are sleeping better. They are sleeping better on all aspects of the Pittsburgh Sleep Questionnaire, and they're more alert, as you would expect, on the Epworth Sleepiness Scale. This is subjective, but it's also been shown on objective measures such as actigraphy, where you see more restful sleep, many different things. Again, another study by O'Brien showed that this was true on polysomnogram. And in clinical trials now, because we know sleep is a problem, in clinical trials such as those done with lisdexamfetamine and mixed amphetamine salts, there was no change in sleep quality either in double blind or in open label. So bottom line, sleep as an outcome for group data with stimulant treatment shows improvement in all aspects of sleep. I'm going to show you 3 studies that we did, demonstrating exactly what I've just described, but showing it to you graphically. So this was a study done with Judy Owens on a methylphenidate product that lasted about 8 hours. And we showed improvement. The children go to bed easier. They go to bed easier because they're not as oppositional when they're not as ADHD. There was improvement in night wakenings and improvement in parasomnias. This is a study we did on sleep in adolescents with a drug that lasted 16 hours. So these are teenagers who have all the problems we described that teenagers have with not feeling tired in the evening, that we put on a stimulant which was present in their blood when they went to sleep. And what you can see on the Pittsburgh Sleep Questionnaire, which is on the vertical axis, normal is 5. So you can see that at the beginning it's 7. Children with sleep problems are showing improvement even in a very short double blind of less than 2 weeks. But most significant from a clinical point of view is what happened over 6 months. So not only did it improve in 2 weeks, but the improvement continued and consolidated, just like we showed for melatonin over 6 months, and got to the point where it was in the normal range, a score of 5. So it got to normal and it stayed normal. We did that in adolescence, and we looked at, Craig Sermon did this work, what we showed before. More people, more patients are going from being poor sleepers to good sleepers than the other way around. So there are some patients, just like we described, who have insomnia at the beginning and go from sleeping well to sleeping less well. But the majority are doing the opposite. This is exactly the same graph, but it's for an adults, and it's the same drug. It's a 16-hour stimulant. And again, you're seeing the same consolidation of improved sleep going down to a score of 5 and staying there for 6 months. And again, the same data showing the percentage of patients that go from poor sleep to good sleep is much greater than the other way around. So now we see that we need to question our assumptions. Everything I've just described to you really changes the game. We need to evaluate sleep before and after treatment. We need to look at sleep as an adverse event in a fraction of patients, and we need to understand that those patients do not tell us about most patients. Insomnia may be present for the first couple of weeks and may disappear over time, so it has to be followed. Stimulants, when there is an adverse event, it can affect all aspects of sleep. So what you need to ask is not just how you're falling asleep, but whether you're staying asleep. And we need to look at all of the sleep outcomes. One of the advantages of using a scale or using a sleep diary. The relationship between sleep duration and falling asleep is almost the opposite to what I was always taught. I was taught if your child is not sleeping on Ritalin, give it earlier in the day and don't give any at night. That only works if the child is not in rebound. When Steve Perrone studied difficulties with sleep on different drugs, he found much more side effects with orous methylphenidate than he did with the 16-hour drug. And I would suggest, it's just a hypothesis, but it works clinically, that the hardest time to fall asleep is not on no medication and not on a little bit of medication, but when you're in that irritable, anxious, hyper-aroused, activated state that is rebound. So with the Concerta, the kids were being taken off medication about 6 p.m., being put to sleep at 7:30, right in the middle of their rebound, and that's what was problematic. The take-home message is, as clinicians, you are not choosing between better management of the ADHD with high doses of stimulant and impaired sleep, or less good management of the ADHD and better sleep. If you want your patients to do well, you have to find a treatment regimen that optimizes the ADHD by day and the sleep by night. So in conclusion, stimulant pharmacotherapy is associated with insomnia in a quarter of patients, but studies show that looking at sleep shows some aspects of sleep may deteriorate while others improve, like bedtime resistance. And when you measure sleep in everybody, more patients are going to be sleeping better than are sleeping worse. Clinically, these are my take-home clinical pearls that have impacted my practice and allowed me to get better outcomes with my patients. I work at sleep hygiene. I use those scales, I provide education, I talk about it. I talk about it as much as the ADHD, and that makes a difference. Patients are more interested. They're now looking at their Fitbits and their Apple Watches. So I think you're going to find you have a ready audience. I work with my families to understand, since the major problem is delay in falling asleep, that the sleep clock is set in the morning. Putting their kids to bed early is counterproductive. It does not work. They want their kids to sleep, wake them up a half an hour earlier every day until they build up a sleep debt that they're so tired they're falling asleep earlier. That takes time. Lastly, understand that the huge use of short-acting melatonin is great for falling asleep, but I believe is actually making middle insomnia, nighttime awakenings, worse. And that responds very nicely to switching from 3 milligrams of short-acting melatonin to 10 milligrams of long-acting extended release melatonin, which is released throughout the night. You need to look at this over time, just like you're working with the ADHD over time, because even in those who have insomnia, it's probably going to go away. And also look at your doses for stimulants. I think we tend to over-medicate. The most impairing symptoms tend to be the attention, and attention may respond to lower doses. And even if there's some loss of effect in hyperactivity, if the child is sleeping much better, that will lead to a better outcome. Look at rebound when you're looking at difficulty falling asleep. Test out my hypothesis, whether extending the duration of the stimulant to a low dose that lasts through the period of bedtime is effective. And then look at functional outcomes, because good improvement requires improvement in the ADHD and improvement in the sleep. I thank you.